guess maybe we'll just go ahead and get started here. We're
Got a good turnout.
late already, so let's start. And let me just start by saying, first of all, wow, gosh, you guys, this is incredible turnout, especially considering all that's gone on in the last few days. And we were hoping that you would still come, because there's still a lot to talk about for sure. So I'm Kat Lyons, and I'd like to welcome you to the Healthcare Town Hall presented by the Anderson Unit of the League of Women Voters of the Cincinnati area. Can everybody hear me okay? Is this okay? No? No? The League is a nonpartisan political organization whose mission is to encourage the informed and active participation of citizens in government and influence public policy through education and advocacy. Today's forum is for informational purposes. The League neither supports nor opposes candidates. Too loud? Okay. Somewhere in between. How's this? Okay. We do, however, take positions on certain issues of which there is a broad consensus among our members. And the League of Women Voters of the United States does have a position opposing repeal of the Affordable Care Act. Back at you. Of course, as you are all most likely aware, the most recent attempt to repeal and replace the ACA has been abandoned in the face of opposition from Democrats, Republicans, and others. This does not however, mean that health care is no longer an issue, and it's obvious that you know that because you're here. So, great. Therefore, our goal for this town hall is a courteous discussion where participants may evaluate the ways in which repeal and replacement, or simply improvements to the Affordable Care Act, may or may not address the nation's healthcare needs and economy. We want to provide an opportunity for all to be heard, no matter what your political affiliation. And I'd like to thank our distinguished panel for volunteering their time to help us learn about some of the complex healthcare issues which are subject to legislative action in Congress, and also sometimes subject to executive action, I believe. So let's listen respectfully with the intent to understand as they give their opening remarks. And I'd like to bring up our panelist, Janet Everhard, MD. Dr. Everhard, you're going to come up to the podium? Are you going to sit there? Okay. Dr. Everhard is a retired OB/GYN who received her MD from the University of Cincinnati. Her private practice was focused on women's health care and delivery and gynecological surgery. She has unique perspectives on dealing with insurance coverage of chronic and catastrophic illness from the points of view of patient, grandmother, and physician. Take it away.
Our lives can change in an instant. In an instant, we can have an auto accident on I-75. In an instant, we can be part of a nightclub shooting on Kellogg Avenue. In an instant, we can get a cancer diagnosis, or a family can get a cancer diagnosis that changes our lives forever. My grandson, Raphael, received a diagnosis of Ewing sarcoma with a 20% chance of survival at the age of 7. You can bet that changed our life. And the question is, the health professionals will rush in, the first responders will rush in to take care of our health problem with no question as to how they will be paid. But eventually, it becomes a question. Will this auto accident, shooting, or cancer diagnosis go from a health tragedy to a financial tragedy for our families and for taxpayers? Someone pays for it in the end. The question, I think, is how is our country going to deal with the fact that there's no life, liberty, and pursuit of happiness without access to affordable, quality health care? We may have dodged a bullet on Friday, but the question is still open. The ACA, although a great start, is in need of improvement. And I hope today that each of you came full of ideas from your personal story, your personal health situation. I feel like I have seen health from all sides. As a physician, I was a patient advocate. As I would fight the insurance companies for my patients. As a patient myself, I lost the use of my hands and had multiple hand surgeries, resulting in me not being able to practice anymore. I have some definite ideas about health delivery from that. But it's truly from the diagnosis of my grandson, from a 7-year-old with a 20% chance to live. And let me tell you, he's doing quite well right now, thankfully. His life depended on the expansion of Medicaid, of all things. His care has cost more than $1 million. It's astronomical. So these are the things that I hope that we can talk about today. I hope that you have lots of good ideas for us, because we need to go forward, and the richest country on earth needs to provide health care for its citizens in the best way possible.
Thank you, Dr. Everhart. Now I'd like to welcome Richard C. Bozian, MD, FACP, to the podium. Dr. Bozian is Emeritus Professor of Medicine at the University of Cincinnati College of Medicine. As university physician, he worked as a clinician and researcher in medicine with a focus on metabolic disease and nutrition. He's also an advisor to Smart Recovery, a cognitive behavioral program for addiction to drugs. And there was a handout. It's out front if you didn't get it yet. Grab it on your way out. Dr. Bozian.
Very good. I'm delighted to have such an audience with the basketball games possible. So. Yeah, I've been involved with addiction since my retirement from the university. During my university life, I was active in metabolic diseases, and including alcohol effect on what have you, but on various organ functions. But I was not involved in addiction per se, and I became involved subsequent to that with my retirement. And in the last 25 years, I've been. How many of you are familiar with programs other than AA and NA or what have you for addiction? Are you familiar with any Smart Recovery, for example? How many know anything about Smart Recovery? Oops, one. Wow. Well, we've had, yeah, right, two or three. Well, we've been battling the battle of addiction for some 25 plus years, as I've mentioned. And actually, the reason why we've had such a struggle is that addiction is a very complex issue. It is not a single, there is not a single causative factors. There are genetic factors. There's always genetic predisposition. Having a gene with respect to addiction doesn't mean that you're going to have it, but it may mean that you have a predisposition to become addicted given the circumstances. A second aspect of it, the first one I mentioned is genetic. Second aspect is a psychological. And psychological includes, believe it or not, half of the individuals that have problems with alcohol, cocaine, heroin, amphetamines, marijuana, or what have you, underlying that are psychiatric or psychological problems. And the individuals become addicted because they were treating the program, and many times these go undiagnosed. Many individuals with problems with drugs and alcohol, what have you, began because of the underlying psychological or medical problems. As you know, the recent tragic deaths that have occurred with heroin and opiates are related to individuals who had significant pain syndromes and what have you, that began taking the drugs for the relief of it and became addicted. And this could be very tragic. But the reality is that alcohol is 10 times more significant than opiates. You know, opiates are very dramatic because people that get overdoses with fentanyl and with heroin and so forth, it's very dramatic for them to be found dead. But the consequences of alcohol are 5 and 10-fold from the standpoint of the long-term damages that occur. The predisposition to many of our degenerative diseases are associated with alcohol abuse in the earlier years, and the alcohol never gets identified as a problem. All right, so to begin with, anything that gives pleasure, anything that avoids anxiety, pain, fear, can become addictive. Anything that gives you pleasure could be, and I don't have the list available, but I can give you 100 things: shopping, use of drugs. I could go down the list. Anything that gives you pleasure has a potential for addiction. Now, why is that? The reason for that is that we are programmed from the standpoint of our central nervous systems for survival purposes to develop habits of performance. And we seek things that will give us pleasure. We avoid things that will cause pain, fear, or anxiety. These are necessary for survival. And we share, our central nervous systems share this with the animals. We have essentially 90+% of the central nervous system programming that the bonobo or the chimpanzee or the gorilla has. But the difference between the human and the animals is that we have an exaggerated, what we call the prefrontal cortex. That's the part of our brain that enables us to understand the consequences of what we do. It is doubtful that a bonobo or a gorilla knows that it's going to die. When they're beginning to reach that point.
We need to move along now, but thank you very much for that. Excellent.
I'm sorry?
Thank you for your words. We need to move along.
Oh, we want to move along. Very good. I can always get back to it. Thank you.
I know you can.
I can go on for hours, but I won't. Good.
All right.
Great.
And next we're going to have Autumn McKinley. And I've been asked to insist that you come to the podium so people can see you. Is that okay?
Well, that's fantastic.
All
I will do
right.
Okay.
So, Ms. McKinley recently joined Molina Healthcare of Ohio as a community engagement specialist after spending over 3 years as a regional director for Enroll America, the nation's leading healthcare enrollment coalition. Autumn has and continues to work directly with consumers impacted by the Affordable Care Act since the initiation of the exchanges in 2013. She has also worked with community organizations and those who provide enrollment assistance throughout Ohio to help educate the public about the Affordable Care Act. Take it away.
All right. Thank you very much. Can everyone hear me? I do have a very loud, booming voice. Fantastic. All right. Oh. Can we? Okay. Does that work better? Okay, great. Nope. Here, does this work? Okay, and I do apologize for the individuals who, like as I mentioned before, I do have a loud voice. I'm the mother of 2 boys, so I'm used to having to speak at a very loud tone on a regular basis. Oops. Here we go. Okay, great. So thank you to League of Women Voters for inviting me to participate in this panel, and thank you for all of you for coming out to join us today. Hopefully we have a very robust conversation and really start to discuss a lot of different aspects, as there has been quite a roller coaster ride in regards to healthcare over the past several months, and some people may even say past several years.
So as the only non-doctor on this panel, I will be here to provide a perspective in regards to some of the work that I've done, working with those who provide the enrollment through available for free through the Affordable Care Act, as well as really discussing some of the viewpoints of some of the things that I've seen for the past almost 4 years of working with legislation, this particular legislation here in the state of Ohio. So for my introduction, I just wanted to give you guys just a couple of key facts. Some people in this room may already have this information. For those of you who don't, just to give you a perspective of where we've been and where we are now. So in 2013, prior to the implementation of the exchanges, we as a state were looking at around a 15% uninsured rate, making us one of the states with a higher level of uninsured individuals within our particular state. Since then, in 2017, we are at a little less than 5% uninsured rate in the state of Ohio. So we have seen tremendous growth in regards to those individuals who have gained health insurance through a variety of different methods through the state, from either expanded Medicaid, Marketplace, or employer health insurance coverage. In Ohio, with the expansion of Medicaid, over 680,000 individuals have now received coverage, which is something that we've heard quite a bit about over the course of the past several weeks, particularly coming from various organizations who work with those individuals, our low-income families, some of our areas where individuals have access to or lack access to particular care, and even coming from the governor of our state, just talking about some of the great work that the expansion of Medicaid has done here in Ohio. Through the federal market exchange, since we are a federal state, sorry for any folks in Kentucky, I don't have information on Connect for you. However, with the federal exchanges this year, over 238,000 individuals have selected plans through the federal marketplace, and that is where people can go in and they select and purchase a plan. So hopefully today we'll be able to dig a little bit deeper into some more aspects of the law. I just wanted to give you some baseline numbers. Last section to that, I want to just kind of localize this a little bit. That means over 50,000 families in the greater Cincinnati area also were part of that 238,000. So there were a lot of members of our community who also went onto the exchange and selected a plan. So today we'll talk a little bit more about the particular law and dig a little bit deeper, but also be able to hopefully learn from each other and leave today a little bit more empowered on what our next steps are. And don't let this conversation end here today. As mentioned before, we have to continue to talk about healthcare. Thank you.
Thank you, Ms. McKinley. Now I'd like to introduce Donald Rucknagel, MD, PhD. Dr. Rucknagel is an emeritus professor of medicine, University of Cincinnati College of Medicine. He is a research specialist and a member of the disease care team in the Adult Sickle Cell Center. He is also an advocate with the Single Payer Action Network of Ohio, and that's spanohio.org if you want to Google it.
Every other industrial nation provides.
There we go.
Okay. Every other industrial nation provides health care for all of their citizens. 15 years ago, the Institute of Medicine, the medical branch of the National Academy of Science, tasked with advising the Congress on medical matters, issued a report in which they said that the healthcare system in the United States is unsustainable in the 21st century. Indeed, 30 years ago, when Hillary Clinton tried her hand at fixing the system, there were 34 million who had neither commercial insurance nor Medicare nor Medicaid. There were a similar number of underinsured people who had insurance, but the co-pays and the premiums, co-pays, and deductibles are so high that they couldn't use it.
Both groups received no primary care and no preventive medicine. When they became ill, they waited until their problems became so bad that in desperation they went to the emergency rooms, where the law says they must be seen. The ERs had no alternative to shifting their costs to those who had insurance and passed those costs along in the form of increased premiums, copays, and deductibles. As these rose, more and more people and companies were priced out of the system to send more people to the emergency room to shift more costs. In 2010, when the Affordable Care Act was passed, the number uncovered had risen to about 48 million. Even with the Affordable Care Act, there are still 28.5 million uninsured, according to the Kaiser Family Foundation, which tracks those numbers. And that dynamic of cost shifting still continues. So we need a national health program in the United States, but our system is such that we'll not have it nationally until we have it in the state or two. In the 1930s, Supreme Court Justice Louis Brandeis said the states are the laboratories of democracy. 20 years ago, the Single Payer Action Network of Ohio devised what is now the Ohio Health Care Plan, that is now before the legislature as a constitutional amendment. If we could get it enacted, everyone in the state would have comprehensive medical care, including prescription drugs. It would be publicly funded. That means taxes. The benefits are legion. It would improve the health of our citizens and be a boon to business in the state. Our challenge now is to get it enacted. As a matter of fact, this Tuesday there's going to be a hearing in Columbus with Senator Mike Scandell is going to be discussing it before some committee. Thank you.
Thank you, Dr. Rucknagel. We do regret that Dr. Stephen Fagan's Vice President of Medical Affairs at Mercy Health East Market was called away at the last minute for a clinical emergency and is unable to be on our panel today. Fortunately, Karen Swiderski, Karen, hold up your hand there, thank you, has agreed to be a resource from the hospital administration point of view, and she has worked as an administrator in the areas of primary care, occupational medicine, and mental health, and she will field questions from questions as an audience member, should the need arise. And also, I was supposed to say community medicine, right?
Yes, academic and community.
So she's experienced all the way around there, so thank you for being here, Karen.
You're welcome.
Okay, well, we also regret that Representative Wenstrup won't be joining us this afternoon. Although we worked at great length with his scheduler and were able to offer him a total of 8 possible dates over 3 months, this week we were notified that he had a scheduling conflict. Yeah, both Rob Portman and Senator Sherry Brown were also invited somewhat belatedly, but since we weren't able to give them an extensive advance notice that we gave Representative Wenstrup, it was a long shot and they couldn't be here. However, Senator Sherry Brown very kindly provided a letter, which he's asked that we deliver for him to you. Dear fellow Ohioans, thank you to the League of Women Voters for organizing this event and all the panelists who are participating. I'm sorry I couldn't be here to thank you in person for all your work to make sure millions of Americans have affordable health care. 4 months ago, it seemed all but certain that Congress would repeal the Affordable Care Act. Friday, we stopped those plans in their tracks, all because people like you stood up and spoke out. I kind of got goosebumps going on here. You called, you wrote, you organized, and it worked. Thank you. You helped secure this victory for the parents I've met whose children are getting life-saving care for pre-existing conditions, for the thousands of Ohioans getting treatment to finally kick their opioid addictions, for seniors and rural hospitals, and 900,000 Ohioans who have insurance today because of the Affordable Care Act, many for the very first time. We know that no law is perfect, but it's working for hundreds of thousands of people in our state. Efforts to take their health care away have failed. It's time to move on and work together to lower costs and improve health care for everyone. I have some ideas about how we can do that, and I look forward to hearing from you. What we saw on Friday is proof that you, the people, still hold the power. You hold the power to make life better for your fellow Ohioans. So I'm asking you to continue organizing, continue putting together events like this one, continue posting on social media, and rest assured you are making all the difference. Thank you. Sherry Brown. Okay, I think we are actually to the point where we're going to let you guys talk. We're asking if you want to ask a question that you're going to queue up. Sorry, technical difficulties. Were you going to be in the middle so he could shoot you? Okay. So Pinky's up here with the microphone. If you have a question, you can come up and form a line up here, and she will take you in the order in which you come up. And just a reminder that this is a nonpartisan forum, and we respectfully request that you maintain a polite tone to promote constructive dialogue. This is a District 2 event, so you may address your question to Representative Wenstrup, as well as to Senator Portman or Brown, or any individual panelist, or the entire panel. So Pinky's going to explain why it's going to work for you to address empty chairs. And keep in mind that we are here to ask questions of the panel and keep any statements brief. Pinky, your turn.
I think I'm going to try to move around you so that we can get to everybody, but we are recording this, and so whatever you have to say, whatever your question is, will be sent to the 3 people who have not joined us today. So we're looking forward to your questions, and I'll just stand here, and if I can get to you, I will. All right, we've got a yellow card in the back here, and make sure, as you've said, that everybody speaks well, loud.
I just would like to hear a little more about this comprehensive bill up in the State House. Is the text online? What are the details of it? Are there any statements? You mentioned that there's a hearing on Tuesday. Tuesday? Yeah, yes.
This question is for Dr. Rucknagel. Loud.
Yeah. Is this better? The bill, I think it's a very creative bill because it not only says there shall be a publicly funded healthcare system equivalent to improved Medicare for everyone, but it also has embedded in it how it's to be implemented in the state, and it's to be implemented in a way that involves the Ohio Department of Health. For instance, decisions will be made by a governing board that will have 2 people from each of the 7 healthcare regions. The Ohio Department of Health has divided the state into 7 regions. We're Region 4, 8 counties: Hamilton, Butler, Warren, Clinton, Claremont, Highland, Brown, and Adams counties. There'll be 2 people from each of these. So there'll be 14 people, and it will be chaired by the Director of the Ohio Department of Health. Now, we started off trying to get it on the ballot as an initiative petition almost 20 years ago. The insurance industry, when we started, they gave a contract to a company to track us, to pay attention to us, and they got an amendment passed saying that doing away with the system of citizens' initiative petitions, so it now has to be a constitutional amendment. That's actually a process, a favor for us, because it's easier to get a constitutional amendment than it was to get a bill passed through the old system. So they did us a favor in that regard. I think that's...
I remind you too that to please direct your question to an individual. That would be helpful.
Well, maybe my question is partly rhetorical, and I didn't know before I came that Dr. Rucknagel would be here, but I'm a proponent of single payer, and I get so frustrated when I watch pundits and politicians on TV discussing it, because they always dismiss it like it's some kooky idea, when I think it's the most cost-effective and fair. It's the greatest freedom for patients. It seems to me you would have, instead of narrow networks, you would have access to any licensed healthcare provider or hospital. But the main thing is we already have single payer in this country. We have Medicare, and it's a very popular program, and the administrative costs are just tiny compared to private health plans. And on the other hand, you couldn't ask for a nicer country than Canada, and they have single payer, and they love it. I think it works really well there. So, well, it was rhetorical. Why do they dismiss it out of hand on TV? But so basically, I think I'm trying to get single payer to be part of the mainstream conversation and not shunt it off to the side. Thank you.
Can I speak to that? Can I speak to that?
Dr. Everhard will speak to that.
In the House of Representatives, there is a House Bill 676. This has been introduced before, and it was reintroduced in January of this year. It's the Expanded and Improved Medicare for All Act. At present, I just looked it up, at present it has, in February, was referred to the Subcommittee on Indian, Insular, and Alaska Native Affairs. How long will it be stuck in that committee? Probably in perpetuity, but when you, Representative Wenstrup, hopefully there will be some questions and concern from your constituents about H.R. 676, and they will stand behind that. Please read it. You can go on congress.gov to read all of these bills. Please read H.R. 676 and see what you think.
All right, we have...
Yes, my name is Gary Harrison. I just want to pose a question to the panel. I do believe the events of the last week or so have shown that America has turned a corner. We do believe existing preconditions must be covered, and we have embraced the essential health benefits that were enshrined in the Affordable Care Act. I believe, no matter where we stand politically, those now are the basis we move forward for insurance in our country. However, we have heard so many charges about so many counties, single payer, companies going out of business that provide insurance. Where's the truth? Who is going to give us the facts so that we can work with our Congress to build a healthcare system that enshrines the coverage of pre-existing conditions and the essential health benefits?
Do you want to direct this question to somebody in particular?
Well, I thought Mrs. McKinley, but anybody else?
Okay. So when looking at the changing kind of markets in regards to what's insurers are consistently in a market, I think one of the most important things for people to really be able to focus and actually know who is going to be in your insurance marketplace from year to year is through healthcare.gov. We have to to a certain extent, start to now learn to parse information. We have information coming from so many different perspectives on things that are assumptions, are alluded to based on a confidential conversation from XYZ source that don't get down to the actual processes of how things are done. So one of the key things I think for individuals as you are starting to seek where do I find my most trusted entities to find that particular information is really start to evaluate some of the sources that are available to you that are just giving directly from particular areas such as healthcare.gov, things that are coming from the Department of Insurance. I think also there's a big area of education that we have to have for people to understand the power of Ohio's Department of Insurance and how state insurance works with federal legislation. So there's a lot of homework, and I'm sorry to say homework that may kind of freak some people out there, but there is a lot of homework that we have to do individually to start to really understand how all of this works together. In regards to really understanding too, you want to not only educate yourself on who's leaving the insurance marketplaces and what's affecting there, but also what plans are coming in. Over the course of doing this work for the past 4 years, we have seen insurers come and go. Myself, I currently am with Molina Healthcare. We are definitely committed to making sure we're providing quality care for our members, but we are a plan that is also in the marketplace and a Medicaid provider, one of the 5 managed care plans here in Ohio as well. But also from my role in Enroll America, I am also kind of kept in the loop before as far as what plans are leaving. Here in Ohio, Southwest Ohio, for example, Humana is one of the plans that has proposed that they will not participate in 2018, which does have an impact greatly here locally. So when seeking this information, plans will have specific dates set when they have to submit their information to the state for approval. Once that's released, there are official announcements released through Centers for Medicaid and Medicare Services that will tell you who are the people providing in-person assistance, the federal navigators. That's just a term that some of you in this room may not be familiar with. There are people who did receive federal funds to help provide free in-person assistance for people to sign up for health insurance. Locally, that has been the Free Store Food Bank for us here in Southwest Ohio, as well as another organization by the name of Resolute Group. That information will come from Centers for Medicaid and Medicare Services. In addition to that, there will be an official release of what plans are being offered that have gone through a review process that has been set out through both federal and state legislation in regards to what plans will be available prior to the November 1st start of your exchanges, so that information will then be available then. And I know that kind of puts people a little bit further away. You may want something more immediate, but there are those processes that's where I want to say make sure you're familiarizing with yourselves with these entities who govern how all of this works, because they are kind of the final say on who, what, and how things are going to end up being sent out to consumers.
Okay. We have another question here.
Yes. I'd like to, Dr. Rucknagel, you talked about the Ohio proposal, and you talked about 2 representatives from various counties in Ohio that are apparently analyzing this. Are they going to be the people who are going to decide what's covered and what's not covered? Who's going to, if that bill goes through and we get insurance from that particular organization, who's going to make the determination of what services we can get with whatever we're paying into that plan with taxes for it? In other words, how's it going to work? Today, if I have to go to a specialist, I have to get a referral from my primary care physician. Then my primary care physician has to get that approval, goes to the specialist. The specialist then determines what my problem is and determines whether I need surgery or I need therapy or I need some sort of medication. How's that all going to work in this Ohio proposal that you're talking about? And I have a question for this young lady. Go ahead.
Presumably, that policy board would make those decisions.
Louder.
That policy board would make those decisions. Let me say that if that, and if they, for instance, would also make the decision as to how physicians are going to be remunerated and paid.
Louder, Don.
And if they are too draconian in how they handle physicians, they'll simply drive them over to Kentucky and Indiana.
Well, the problem is you got 14 people, I think you said, where that board, those 14 people can't make decisions for all of us in this room.
Well,
There's
first
no
of
way to
all,
do it.
I don't know if it got enacted and passed. The legislature would alter it, so that's not all set in stone.
Well, that's just like the
Sir, let
death
him answer
panels
the
they talk
question.
about with Obamacare.
Well, I think that's all.
I can't hear you.
I think that's not set in stone. Okay, is that
better?
all right? That is exceedingly complex, and the legislature would have a lot of leeway in altering that. Let me say that, well, since I have the microphone turned on, we have House Bill 676. We don't have a Senate bill to accompany that, number one. Number two, part of the reason for going first with the state is that we're a very heterogeneous company or country, and one needs to show politicians that they can survive after getting involved in it. And secondly, you have to show that it works, and that's the case for starting in the state or two before we go national.
Thank you, Don. Can I jump in? Is this on? No. You know how it is. Let me jump in. One thing you can always count on. One thing you can always count on, if you get more than one doctor around each other, we will always disagree. We have a popular and proven healthcare program in our country, and it's called Medicare. And I would like to know, those of you who are on Medicare, especially if you've negotiated the Medicare Advantage plans, you have an affordable, effective, it's suited just to you because you need drug coverage, so you chose the plan with drug coverage, and maybe you need health hearing aids, or maybe you just want silver sneakers, or whatever you wanted. You chose exactly what you wanted. It only added because of the competition of those insurance companies that are administering the Medicare Advantage. You only added $15 a month to your basic Medicare charges. Not even that. Some are zero. Mine, 17. But you can hardly find a senior that isn't absolutely thrilled with their Medicare. And for us to take this popular, proven program and introduce it as the public option in ACA, when insurance companies decide that they want to throw a hissy fit because they didn't get to merge with another company, and they're putting us, they're making us pay for their non-merger plans, put those people on Medicare. Medicare cannot be instituted all at one time. Hospitals, we might be able to get some information from Karen as to what would go on with the hospital industry, but I've heard and conferred with experts, some of the professors at Xavier, and they've told me that if we were to all of a sudden, boom, go to Medicare for all, it would throw the healthcare industry into a tizzy. They're not ready for that. But they have said to me that over time, if we did an incremental movement into Medicare for all, that the hospital industry, doctors, big pharma, device companies, whatever, could adjust to that level of reimbursement. And there's many ways that people have ideas about how to incrementally move in Medicare for all, and that might be something that you all could think about. I've heard it proposed, and I agree with this, that the most highly subsidized patients of the ACA, the ones that are costing the ultra-wealthy taxpayers the most, if that subset was offered Medicare, and then in the next years after that, the next subset could be added to the Medicare program until all the ACA patients are on Medicare. Then you could opt in private insurer patients if they wish to be part of the system. And when you have the majority of your population on Medicare, that's when the function of negotiating with big pharma, with device companies, with whatever entities are making this incredibly fragmented, over-expensive healthcare system that we enjoy in this country into something that's lean and mean and good for the taxpayer, good for all of us. That's my idea.
To kind of dovetail off of that, Congressman Wenstrup, what do we do about the immense amount of money in lobbying that is going into blocking movement and protection of the ACA movement towards a single payer? There's an immense amount of money coming from insurance companies and other lobbying groups, and that concerns me. What do we do about that?
Question for the empty chair. Did you?
Yes, I do have a question. I'm addressing this to probably Dr. Everhart. When the ACA was first being promoted, it was described and is still described as scary words: socialism, government-controlled health care. Yesterday, Wenstrup posted on Facebook after the bill was withdrawn that he was very sorry, but he would do what he could to help the Americans who were still suffering under Obamacare. And that's a direct quote. If you recall, back at the time that the ACA was first proposed, there was talk of death panels. So how do we, as a group, go out and communicate that this is not socialism, not death panels, not suffering under single-payer health care? And how do we communicate that to our sons, daughters, and grandchildren? Because they're the ones that we need to make sure are healthy long after we're gone. I think one way to do it is to say that we're ensuring the health of the future economic workforce. So any suggestions from any of the panelists of how we as individuals can frame this argument?
You know, what you just said is excellent, especially that ensuring the health of the workforce. Sometimes we have to do a paradigm shift. Most of us are thinking about our own and our own families' affordable access to quality health care. But in political speak, sometimes we have to talk about what this will mean for the workforce, what it will mean for taxpayers. Yes.
The moral center of the argument.
Mm-hmm. I will say that if you look back on the history of trying to, the political history of healthcare, it's a fascinating history. When you go back to Truman, when you go to Lyndon Johnson, what has been proposed by the different parties, how it's just gone into oblivion and hasn't happened over and over. I mean, it's a fascinating history. We missed so many chances to have this. And oftentimes, it would be the American Medical Association that would shoot it down. Sometimes it would be the unions that would shoot it down. Sometimes it would be the various political egos shooting it down. It's an interesting story. It'd make a great movie if it weren't so tragic. Maybe that's it. It's tragedy and comedy and all that politics can be. But it comes down to, as all political things come to, as constitutional rights. Some will say that health is not a right. It's not in the Constitution, and that's what I alluded to right off the bat, that there is no life, liberty, and pursuit of happiness without access to health. It doesn't exist.
All right, we've got a question in the back here.
Could I
Could I respond to something?
Nice and loud, Don.
Speak up.
Oh, to the person who wanted to know how we're going to offset the insurance industry, we're going to have to raise a lot of money too. And we have two mechanisms for doing that. Number one, we're a 501c4 organization, but we have a 501c3 educational fund also. Plus, we intend to use crowdfunding. So we're going to have to, now we're not going to be able to match them, but we do need enough to have a credible advertising campaign. So we're very much aware of that issue. Secondly, socialized medicine is when the government owns the hospital and all of the employees are on salary. There are only the two institutions that I know where that's the situation is number one, Great Britain, and secondly, the United States Veterans Administration.
Okay, we've got a question back here.
Oh, yes, my name's Bob Drake. I would ask us to share ground were he here because I trust him to give me a straight and honest answer, but he isn't here. So I'd ask any of the panelists if they know. I firmly believe that the ACA has been given a reprieve. It's not been saved, and that the forces arrayed against it will do their darndest to sabotage it, to not tweak the tweaks that need to be made, to nip away. What should I look out for? Does anybody know? Can you explain to me what's going to happen? What will they do next? Because they are going to attack it and let it engage in the so-called death spiral so they can stand back and say, see, it didn't work. It's no good. It's blowing up.
So looking to that, this is where I asked for people to call upon some of the things that they've been currently doing when reaching out to their legislators and talking about all of the success, all of the great stories. But once again, I'm going to be the teacher here today to give you homework to learn all perspectives when looking at that law and then really starting to come away with ideas. One of the things that was discussed here in this room is to be able to leave with some ideas of things that can work in our current system and being able to send that information off to the legislators that are not here today to make sure that they hear from our voices. But it goes beyond just this room. You still have to continue to maintain continuous conversations with your legislators and continuing to educate yourselves on what were those success stories, but also what were those problems that people faced. Because the reality, and I feel like this is a sentiment that we've read a lot in the papers, that there is a consensus on Capitol Hill that there are changes and there are things that need to be done to help the ACA continue to help individuals. And as I always say in presentations, the ACA has now created kind of a standard that now we have to move beyond that. This is a status quo, now we need to do more. So in regards to what can you do right now, if you have been writing, calling, and continuing to put pressure and continue to ask questions, now continue to do so, but also offer solutions. Do not just say that this is now, we have moved past one particular proposal and now everything is just going to let lie and be there. Continue to ask questions, seek answers, hold your representatives accountable, and offer solutions, because everyone needs to participate in that process, because healthcare impacts us all. Healthcare impacts more than just your health, but also the general function of your community. And so that is something that we in this room have the right to continue to put the pressure on and make happen.
Oh, I say bravo to that. I say bravo to Autumn. That's wonderful, because we have gotten in a reactive mode. And we protest as a reaction to something terrible that's coming out of Congress. And instead, we need to be proactive. We need to educate ourselves and come up with your individual plan and let your legislators know. Proactive, not reactive.
Let me point out that there are still 25 million people who are uninsured with the Affordable Care Act, and those people are still, those costs are still going to get shifted. So the premiums are going to continue to go up, and people are going to continue to be priced out of the system.
Hi, my name is John. I'm actually a licensed insurance agent and deal with Medicare specifically. And in my dealing with my clients, I get a lot of people who are confused between ACA and Medicare. They are two completely different programs, and they're hearing the complaints or the things that what's going to happen with ACA and thinking it's going to happen with Medicare. This is for Ms. McKinley and Dr. Everhart. What can you tell these folks? I'm looking here, it's a good mixture of people. Medicare is a great program. If you ever want to know, I can tell you all about it. But the ACA is a completely different animal. And there's a lot of, listening, there's been a lot of confusion.
There's so much confusion. In fact, we realized that voters thought that Obamacare and the ACA were different things. So voter education is extremely important. But the Medicare system has been strengthened by the ACA. Its money pool is going to last longer because of the ACA. It's stronger together, different but stronger together.
And so I'm just going to actually kind of throw a quick question in regards to this to the room to see how many people know about this. How many people in this room are aware of Ohio's Medicare dual eligible program? See, there are a few hands, not a lot. So even adding to that, there are many aspects from a state perspective as well as kind of looking at that national perspective that unfortunately the only thing I can really say to you most important is to continue to educate. I've participated in phone-a-thons that we used to do with WLWT during the open enrollment period, and we would see a significant percentage of people calling in who were seniors who were, this doesn't line up with my enrollment, am I missing enrollment? Am I doing something wrong? People had a lot of confusion. So really that does come down to looking at the organizations that are out there that have some of that funding to help provide some additional education. Also looking at the insurer to make sure we're putting out information describing those different programs so people can consistently have multi-touch points, which I think is very important to educate them about the process. Medicare dual eligible. We here in Ohio have a program for individuals who are Medicare and Medicaid eligible. Okay? So that is something I work with because Melina is one of your providers here in Southwest Ohio. But that also just goes to show, even in this room, we still have a lot of information to get out to people, and some of that will become confusing, and that's where looking at what resources, what networks, for those seniors who may not have a large network to kind of help them with their care, what are the nonprofits, what are the other organizations out there that can help be that additional multi-touch point to help them navigate through the system, such as yourself as a licensed insurance agent. You are that trusted entity for them to walk through that process and really build your team. Each and every one of you, when you walk out from this room, think about who is your team. Who are the people who are there to help protect you and you work to protect them? Because the reality is we need a team in order to be able to make sure that we're educating ourselves and really understanding all of these different processes. Because I could even ask this, how many people in this room for their own personal health insurance know back and forth everything about your insurance?
I always raise my hand.
Just a few of us, exactly. So we all have to also take on some level of responsibility to make sure that we do those things because you don't know what you don't know. And you also don't know what someone can get over on you or what you have access to, and once again, if you don't know.
All right, well, the League of Women Voters is a community partner that has started the process here. So I just have to pat ourselves on the back. Here's another question.
Hi, I'm Stacy from Loveland, and my question is for Senator Portman and probably more towards Senator Brown. I was very pleased to see the bill pulled, but I was very disheartened at the attitude of the Republican Party and to this gentleman back here. They are going to try to do everything they can to sabotage what we currently have, which even though it isn't perfect, it's a step in the right direction. So I guess this is more for Mr. Brown. I want to know what the Democratic Party is going to do now. And we saw what happened with the Republican Party that's not unified. We need to unify. And I call myself a Bernie Democrat, and so I want to know if the Democratic Party as a whole, if their next step is to push for single payer. Because whatever our next step is, we need to be unified. I've heard the term missed opportunities. I've heard the term being proactive. I think right now is a really great time for progressives to figure out what we do and unify together and to get behind a cause and not see what just happened Friday happen on our end.
Yes, it is. In fact, I need to ask myself to go back to the party platform and to see if that has been addressed. It certainly should be addressed post haste and in the platform.
Okay, we've got another question in the back here.
The gentleman here, the insurance guy here, has said that there was an essential difference between Medicare and the ACA in terms of what were you talking about? How is the ACA in the end, which would be single payer, how is that different than Medicare, which is single payer?
Well, Medicare,
I don't understand what you're saying about the insurance thing.
It's basically Medicare is controlled and monitored through the CMS. So a lot
What
of
is that? What is the CMS?
That's what controls Medicare.
I'm sorry, that's Center for Medicaid and Medicare Services.
Medicare is for people over age 65. That's one reason.
The ACA, which is for people who are generally under 65 or not eligible for Medicare, is for everybody else. And it's just generally the insurance companies are going to be in there competing for your business. And it's
Private.
that's a political issue. That's not, but there is a difference between the two programs.
There are many people under the age of 65 that have Medicare. Anyone with a disability after 2 years has Medicare. And there are many Medicare patients that have Medicaid, like Autumn was saying, dual eligible people. So there is, but these are still entirely different. The ACA with your and go on healthcare.gov. Take a look at what people on the ACA get to choose from. Go on Medicare, probably .gov. It seems similar in a lot of ways because some of those insurers that are on the Medicare Advantage and on ACA, you'll see Anthem, and you'll see if you look in all the if you look in the benefits and the doctors involved, and they're certainly look alike in a lot of ways, but they're administered separately.
And I will say just also one thing to kind of looking at the perspective of plans. Not all plans are created the same. So that is something that when you are looking at plans, that's another part to really kind of learn to differentiate, and that does kind of look at some of the differences as in regards to some of your options that you have, even from your employer. Many of us through our employer are offered multiple plans, even from sometimes multiple insurers. So we then have to start to look at those particular plans and which plan is going to be the best for you and your family. So that is one area kind of looking at the insurance that's in the ACA and thinking about Medicare, that those plans are set differently, and what they're covering and kind of what the offers and what the breakdowns look like do look a little bit different from looking at group insurance, even some of the insurance plans that are in the exchanges and Medicare.
There's also a big difference between the ACA and Medicare on where money comes. Sorry. You may know that in the ACA that the very most wealthy people in our country are being taxed heavily for the ACA. This is one of the reasons for the backlash against it when political officials, public servants, I guess, have big money in their back pocket from the ultra wealthy who are paying costs of the ACA, whereas Medicare has multiple revenues, general revenues, and so on.
All right, we've got another question in the back here.
So the question has been posed, my name is Marcia, in our county. How can we communicate the facts? We trust the facts on the ground. ACA is exploding the wires, and then definitely being sabotaged. I watched this, and something occurred to me is two things happened.